In this presentation, we're going to take a look at some examples of abnormal oral mucosa through the VELscope. We'll use what we've learned from the earlier modules and try to make sense of not only what we see with fluorescence visualization through the VELscope, but also how it relates to what we observe under white light. As we move on to considering genuinely abnormal mucosa, we should remind ourselves of some general principles. Evaluation of a suspicious area should generally be made in comparison to the contralateral side. Areas that show an irregularly shaped but relatively well delineated reduction of normal green fluorescence compared to surrounding tissue of the same type and to the equivalent location on the contralateral side should be watched carefully. Also, be on the alert for fluorescence patterns that appear to be out of context or unexplainable. When you see something under fluorescence that you really didn't expect to see, based on what you saw under white light, a good question to ask is always why. This should generally invite some further investigation of the area. Finally, abnormal patterns, whether they be under white light or under fluorescence that spread across different anatomical structures, should be investigated closely. This is a very simple example of bilateral presentation. The dark area on the right-hand side of the mouth has an equivalent dark area on the left-hand side. Of course, we've already discussed that the anterior tonsillar pillars typically appear dark under VELscope because of vascularity. But even if you didn't know this, the contralateral symmetry is generally a good sign that this is not a manifestation of disease, just normal anatomy. Blanching a lesion using diascopy has been a differential diagnosis technique in assessing oral lesions for a number of years. It involves compressing the tissue with a tool to locally empty blood vessels and thus reveal the vascular nature of a particular lesion. Inflammation, which involves intact, dilated blood vessels, will typically blanch. Due to the high contrast under fluorescence visualization, using an instrument to blanch a dark area under VELscope can be a useful technique for indicating whether or not an abnormality has an inflammatory component. Let's take a look at this example. This particular area blanches completely. Treatment and subsequent follow-up after 2 weeks resulted in complete resolution. The fact that tissue doesn't blanch is not necessarily a bad sign. Here is an example of some dark areas on the side of the tongue that did not blanch. It turned out that this particular abnormality was an ecchymosis, a type of soft tissue hemorrhage. When the patient showed up for the standard 2-week follow-up visit, the situation had resolved and the dark areas were gone. It should not be surprising that we might have trouble trying to blanch an ecchymosis if we stop to remember that for a soft tissue hemorrhage there has been vessel damage and blood has spilled out into the surrounding connective tissue. This makes it more difficult to blanch because the blood is no longer inside the blood vessels. The dilated blood vessels that occur as a result of inflammation can easily be blanched because the blood is still inside the blood vessels. This is an amalgam tattoo, a type of pigmented lesion. Given our discussion about how and why blanching occurs, it should be quite clear that a pigmented lesion will not blanch. The pigmented material does not reside, like the blood, in the vasculatory system where it's mobile. Thus, it cannot be moved out of the way using diascopic pressure. Using diascopic pressure to try and uncover the vascular or non-vascular nature of a particular area is, however, a subtle tool that must be used with care. Remember, we saw that one of the responses of the body to dysplastic growth can be inflammation. Our expectation for a dysplastic or cancerous area with inflammation should be that the parts of the lesion may blanch, inflammation, and parts associated with intrinsic loss due to dysplasia or cancer will not. Here is an example where an area of severe dysplasia shows evidence of blanching in perhaps the most clinically obvious area. See the picture on the lower right. The clinician from the University of Washington who performed this exam told me careful use of the blanching showed some areas of residual loss of fluorescence. The lesson is, blanching usually indicates an inflammatory component to what you're looking at, but it doesn't necessarily mean that it's an inflammatory lesion. This is a brief movie of a lesion which, as it turns out, shows loss of fluorescence from both dysplastic and inflammatory effects. Notice the general abnormal fluorescence pattern showing extensive areas of loss of fluorescence. This is the same patient as in the previous movie. Initially, we're seeing the other side of the tongue, which has a completely normal fluorescence pattern. Watch closely as the patient moves their tongue so that we can see the other side of the lesion. Notice that the anterior part of the lesion starts out showing no loss of fluorescence and quickly becomes dark as the blood rushes in and fills the blood vessels. Let's take a look at that again. Did you see it? This area of the lesion would undoubtedly have blanched under diastolic pressure. It's a good example of how inflammation and dysplasia and/or cancer can coexist in a lesion, and both can give rise to a loss of fluorescence. In this slide you can see a rather subtle area of redness or erythema that did not blanch under compression when the corresponding dark area was blanched under fluorescence. This area was found to contain dysplasia when biopsied. In this movie, there is evidence of blanching in some areas, but it's also quite clear that this lesion does not completely blanch, especially around the anterior part of the lesion. This lesion was found to contain dysplastic tissue. So here are some important things to remember about blanching. Blanching can indicate that an abnormality has an inflammatory component. Soft tissue hemorrhages, such as an ecchymosis, may not blanch. Pigmented lesions are not going to blanch. Although we might expect a precancerous or cancerous lesion not to blanch because of the associated intrinsic loss of fluorescence, as explained earlier, we must remember that cancerous or precancerous lesions typically have associated inflammation. Therefore, they may partially blanch. However, the bottom line is that not only should an abnormality that does not completely blanch under VELscope be carefully followed, so as to determine its cause and/or rule out dysplasia or oral cancer, but also an abnormality that does completely blanch but persists is of equal concern. And this is a very, very important point. So moving on now, here we see an interesting example of a palatal torus, which despite the extensive keratinization that is evident under white light, which would tend to increase the fluorescence since keratin fluoresces, presents as a predominantly dark area through the VELscope. This turns out to be quite typical of palatal tori. The current hypothesis about why this occurs is that there is a relative lack of connective tissue because of the way the mucosa is stretched over the bony protuberance of the torus. A thin layer of connective tissue means that there is not as much highly fluorescent collagen, and this collagen is thought by most experts to be the brightest fluorophore in the oral mucosa. Given the understanding we've gained so far about why the fluorescence visualization through the VELscope appears the way it does, the appearance of this case of migratory glossitis under VELscope should be of no surprise. The atrophic patch on the dorsal surface is an absence of filiform papilla, and thus an absence of fluorescence from the corresponding keratin. In addition, the reddened, inflamed areas contribute to the dark appearance as well. The classic, raised, white, keratin-dense borders predictably look bright when viewed through the VELscope. The key concept to grasp here is that there is no additional sign of risk or concern based on the dark appearance through the VELscope, because it is manifestly explainable by the presence of the relatively simple features observed under white light. Here is an example of so-called white hairy tongue. the extra-long, keratinized filiform papilla show up very brightly under fluorescence, as we would expect. This was a patient from a private practice who came to the dentist with a denture plate in her mouth, kept in place with so much denture adhesive that, in the words of the dentist involved, I practically had to use a crowbar to get the plate out of her mouth. The resulting inflammation of the salivary glands on the hard palate show up as little dark patches under VELscope, as we would expect from our discussion on inflammation. The other theme and evidence here is to look carefully at the hard palate under white light again, after observing it under VELscope. The inflammation is also quite apparent there. The abnormal fluorescence pattern is consistent not only with careful observation under white light, but also with the patient history information. Well, this is another example of an ecchymosis, showing up dark under VELscope because of the localized blood, and which did not blanch. As in the earlier example we saw in the movie, this lesion was gone at the 2-week follow-up visit. Here's an example of a permanent dilation of the vascular bed. This is a benign, permanent condition that nevertheless should be monitored for change. This is an amalgam tattoo which shows up as dark in white light, just as it shows up as dark under VELscope due to light absorption. The presence of filled teeth nearby would help confirm the identification of this particular lesion as an amalgam tattoo. It's worthwhile to take a moment here to discuss pigmented lesions in general. The question sometimes arises with new VELscope users. I see a dark area under VELscope, or I observed a pigmented lesion under white light. Should I worry? The first answer to this question is that you should expect a dark area under fluorescence from a pigmented lesion under white light. We know from our science discussion in an earlier module that the same tissue optical processes that lead to absorption of light, as in a pigmented area under normal conditions, will also absorb excitation and fluorescence light when observing through the VELscope. The secondary question becomes, does the area through the VELscope have the same shape as what was seen under white light? If the answer is yes, then all is as it should be, and the lesion should be treated as it would have been treated had the VELscope not been used. If the answer is no, then further investigation is probably warranted to understand the reason for this. Needless to say, patient history and clinical judgment will play a large role in helping you deal with these situations comfortably. This, obviously, is an aphthous ulcer. The inflamed ring around the ulceration, which under white light looks erythematous or red, predictably looks dark through the VELscope. Fibromas are an interesting application of some of the fundamental science lessons we learned earlier. They are comprised mainly of poorly vascularized connective tissue. The collagen in the connective tissue fluoresces strongly, and because of the lack of vascularity in the connective tissue of a fibroma, there is little blood absorption. Thus, we would expect fibromas to be neutral or slightly brighter in appearance, as is evidenced by the examples on this slide. Squamous papillomas are an interesting illustration of some of the concepts we've learned so far. The structure of the papilloma involves highly vascularized fibrous projections which are thrust up toward the surface of the mucosa. The blood absorption in these high vascularized projections leads, quite logically, to a loss of fluorescence. This reddened residual nodule of lymphoid tissue, situated approximately at the area of the palatine tonsil, previously excised in this case, looked very dark under the VELscope, as one might expect, based on its appearance under white light. It could be argued that in this particular case, the appearance under VELscope brings no additional value other than the fact that the areas of darkness exactly correspond to the areas of redness under white light, and no more. In this case, the dramatic appearance under fluorescence does nothing more than to help alert us to its presence, which in this particular case it did. But the presence of darkness corresponding to redness gives us no additional cause for concern above and beyond what the presentation under white light does in and of itself. If there were dark areas extending away from the lesion, not corresponding to the red nodule apparent under white light, this would give us greater cause for concern. The bright yellow appearance under the VELscope can be indicative of the proliferation of the fungal organism Candida. Under white light, the appearance is similar to clinical leukoplakia. The fluorescence from both the keratin and from the hyperkeratosis lead to the bright color from the main lesion, but notice the loss of fluorescence around the borders of the hyperkeratotic area, consistent with an inflammatory response. Here is a herpes simplex virus lesion, where the intense inflammation, as evidenced by the erythematous area on the soft palate, looks predictably dark under the VELscope. The surface keratinization, symptomatic of smokeless tobacco keratosis, makes the labial mucosa here look brighter than normal, as we might expect. This is lichen planus on the buccal mucosa. Notice how the inflammation evident under white light is better visualized as areas of darkness through the VELscope. Although somewhat controversial, chronic lichen planus is sometimes regarded as a possible pre-malignant condition, although only in about 1 to 2% of cases. Distinguishing fluorescence loss associated with inflammation from that associated with possible dysplasia could very well be problematic in a typical case of lichen planus. Research continues to be conducted in this area. As it turns out, in this particular case, dysplasia was indeed found in the upper part of the lesion where the arrow indicates in the fluorescence photograph. Notice that this particular area doesn't seem to stand out as much under white light. This is an example of erosive lichen planus, and not surprisingly the inflammation around the central ulceration shows up as dark under VELscope. Notice also that the keratinized tissue and the central fibrin clot show up brighter compared to the surrounding inflammation because of the fluorescence associated with both keratin and fibrin. The intense dark areas are entirely consistent with the inflammation, quite evident under white light, that are classically associated with erosive lichen planus. This should not in any sense be viewed as a false positive, merely the fluorescence response to the tissue processes behaving as expected. This is an instructive example to consider, which comprises a leukoplakic-type lesion together with a fibrin clot on the lateral border of the tongue. The question is, what do we make of this lesion? Does its appearance through the VELscope make us more or less suspicious of potential trouble? Well, we've learned that earlier in this course that fibrin fluoresces relatively strongly under blue light, so the bright fluorescence of the fibrin clot near the center of the lesion is what we expect to see. Areas of fibrin deposition will fluoresce brightly and may mask a loss of fluorescence due to underlying dysplastic processes. In these situations, we look at the areas around the fibrin clot, which are milky white and keratinized under white light. These do not look bright due to keratin, as they would for ordinary hyperkeratosis, but rather dark from intrinsic loss of fluorescence from dysplasia. Contrary to an oversimplistic notion that because the central area is bright it's healthy, the presentation of the lesion under fluorescence, when taken as a whole, helps confirm our suspicion that this lesion needs to be followed up and biopsied. Describing this lesion in some sense as a quote-unquote false negative because of the bright fibrin fluorescence is a rather unenlightened approach to using the VELscope. We certainly don't need a VELscope system to help us find this obvious verrucous carcinoma. This is here to again illustrate the point that an increase in fluorescence does not mean that the tissue here is healthy. The extensive keratin production that is an integral part of a verrucous carcinoma leads to the bright fluorescence. Labeling this a quote-unquote false negative, it's just plain silly. Although not seen in these photographs, the VELscope might have added value to the clinical management of this lesion had it been used to examine the areas around the lesion where there was no keratin. Unexpected dark areas around the borders of lesions when viewed under fluorescence can be of help to specialists during lesion excision. This is an example of a patient who presented at a private practice with an erythematous patch beneath a denture. When examined through the VELscope, a second, smaller patch became quite evident as well. Because of the unusual appearance under the VELscope, the clinician biopsied both areas. The larger, more obvious area in white light was confirmed by biopsy to be mild dysplasia. The smaller, less obvious area under white light, which looks darker with more well-delineated borders under VELscope, was found by biopsy to be moderate to severe dysplasia. This is a good example of how the VELscope can enhance the examination process of the clinician by focusing attention on areas that might otherwise have been overlooked. This is an example of a large area of leukoplakia on the soft palate that was confirmed by biopsy to be moderate dysplasia. Under VELscope, the leukoplakia presents as a dark area in stark contrast to the adjacent healthy tissue on the soft palate. Notice in particular the well-delineated and irregular border of the dark region. This is typical of dysplasia and oral cancer. Even without the fluorescence image, the presentation under white light has all the earmarks of trouble. A white patch, well-delineated borders, etc. Hopefully most clinicians would not ignore this. It is nevertheless instructive to compare the fluorescence presentation with that under white light. This is a good example of how a white keratinized patch, that despite the presence of keratin, which fluoresces, can look dark through the VELscope because of the underlying mechanisms of loss of fluorescence from both the decrease of FAD in the epithelium and the breaking of collagen crosslinks in the connective tissue. Notice how these effects reveal the same lesion morphology as in white light, although thrown into a much starker contrast. Here we see another example of a leukoplakic patch, somewhat more subtle and easier to miss than in the previous example, that again is predominantly dark under VELscope, despite the surface keratin. Notice the irregular and well-delineated border thrown into higher contrast with fluorescence. It would be hard to ignore this. This area was biopsy confirmed as severe dysplasia. Here we have a large area of leukoplakia on the side of the tongue, but this time the lesion morphology appears different with fluorescence compared to white light. Under VELscope, parts of this area show up as brighter due to keratin fluorescence, but the areas indicated on the picture by the arrows are, to varying degrees, darker under VELscope. The slightly less dark area on the right-hand side of the image was found to be moderate dysplasia. The smaller, very peculiarly shaped, darker area more toward the top of the tongue, severe dysplasia, and the very dark area posterior to these two areas, invasive squamous cell carcinoma. Here is a worrisome-looking area under white light that becomes more so after the unusual, irregularly shaped dark area that becomes apparent under VELscope. There is little to suggest this particular morphology based on the presentation under white light, and this makes it all the more troubling. Cytology and biopsy showed there to be dysplasia in the area indicated by the arrow. This is a clinical presentation that might present in a typical GP's office, and might on cursory examination be considered an example of denture trauma. Under white light, areas of erythema, redness in the vestibule, and hyperkeratosis on the alveolar ridge are evident. Under fluorescence, the hyperkeratotic area on the alveolar ridge demands our attention with an intense loss of fluorescence. This particular patient was examined in the oral medicine department at the University of Washington. The clinician involved relieved the denture and examined the patient again approximately 2 weeks later. The areas of erythema and corresponding darkness under fluorescence in the vestibule were gone. The intense loss of fluorescence on the ridge remained and was found to contain severe dysplasia after an excisional biopsy was performed. An interesting case from the days when the VELscope was a prototype under evaluation at the BC Cancer Agency. This patient had a prior history of oral cancer and presented to the dysplasia clinic with some discomfort. The specialist who saw the patient assumed it was the area near the small white polyp and was planning to biopsy the area adjacent to it. Before doing this, though, the patient was observed through the VELscope, and the intensely dark area with quite well delineated borders was discovered slightly posterior to the obvious polyp. Because of this discovery, both areas were biopsied. The area near the polyp was found to be mild dysplasia. The newly discovered area was biopsy confirmed to be carcinoma in situ. This is a good example of how the VELscope can help shift the focus of even expert clinicians to dangerous areas that might otherwise have been overlooked. This is a classic case study which was published in the journal Head and Neck as an example of a so-called clinically occult lesion. That is, one that is virtually undetectable under conventional examination. The rather unremarkable appearance under white light is contrasted by the intense loss of fluorescence when viewed through the VELscope. This lesion was found to be carcinoma in situ upon biopsy. The toluidine blue staining of the lesion is also shown in the bottom left photograph, and is somewhat typical of the experience of the researchers and clinicians at the BC Cancer Agency in Vancouver, BC, Canada, who use both tools clinically. The area showing loss of fluorescence is usually larger than the corresponding area that stains toluidine blue positive. Although there is not a global consensus on this, many experts believe that toluidine blue is more specific to higher grades of dysplasia and cancer, whereas fluorescence is quite sensitive to even quite mild types of tissue change, and is thus very good at identifying the full scope of mucosal involvement of a particular lesion. These pictures are from the same patient as in the previous slide, and illustrate another useful function of the VELscope as a tool to help discover satellite lesions away from a primary cancer. In this case, a non-suspicious area under white light and an equivocal staining result under toluidine blue accompanied a marked loss of fluorescence. This area was found to contain severe dysplasia upon biopsy. A rather remarkable image showing invasive squamous cell carcinoma with a secondary infection. Not surprisingly, the bacteria involved in the infection give off their characteristic orange-red glow from the porphyrin fluorescence. The dark area at the top is a previous biopsy site. An interesting note here is the tendency of bacteria and fungi to collect in areas of non-smooth mucosa in the mouth. In this case, the encrusted and textured surface of the lesion is a natural place for bacteria to become entrapped. This is the same thing that goes on in the normal mouth, where you tend to see porphyrin bacterial fluorescence coming from the filiform papilla, or fissures on the dorsal surface of the tongue and the palatine tonsil. Also, the fact that this squamous cell carcinoma glows bright red rather than showing a classic dark loss of fluorescence should in no sense be regarded as a sign that all is well. Hopefully, you've seen enough to understand that this is simply the wrong way of trying to use the VELscope. There can be no doubt that the presentation under VELscope is highly abnormal and warrants immediate biopsy. Here is another case from the oral medicine clinic at the University of Washington. Blinded to the presentation under VELscope, experienced oral medicine specialist judged this to be a case of classic trauma. Upon examination with the VELscope, the hyperkeratotic area of the presumed trauma was found, contrary to expectation, to be dark under the VELscope, with the exception of the most pronounced spot of keratin. Equally important, this loss of fluorescence extended away a considerable distance, both posterior and anterior to the hyperkeratotic area. To the experienced VELscope user, this poses the question, why is that? The fluorescence response under the VELscope is not consistent with expectations of a traumatic lesion. As a result of this type of thought process, this lesion was first sampled using cytology and then biopsied. Abnormal results were found using cytology, even from some cells brushed away from the central lesion. The biopsy result returned dysplasia. This is a case somewhat similar to the previous example, although in this case the oral medicine folks thought dysplasia without the help of the VELscope. What is interesting about this example, however, is that the VELscope added value to the assessment of the lesion by showing the clinicians that the area of concern was larger than what was apparent under white light. Note the extension of the loss of fluorescence anterior to the main lesion. Here is an example of a somewhat subtle presentation under white light that was nevertheless not missed by the experts in the oral medicine clinic at the University of Washington. This subtle appearance under white light is contrasted with the dramatic star-like morphology of the lesion when viewed under fluorescence. The fluorescence photograph shows that the lesion did not blanch under diascopic pressure. It's hard to imagine thinking anything other than this is an abnormal tissue change warranting follow-up. Upon biopsy, dysplasia was found. Yet another example of the scope showing loss of fluorescence that makes an area of suspicion more visible than in white light. The combination of both visualization methods significantly enhances the diagnostic data for decision making. Look at how dark the anterior area of change is on the scope and how vague it is in the clinical view. The dark areas were found to contain moderate dysplasia. Here is a troublesome looking area on the attached ginger that has an intense loss of fluorescence through the VELscope. The red-orange hue to the color may be indicative of some bacterial presence there. The area was found to be dysplastic on biopsy. It can be seen in this example that it is the dentin that gives rise to the intense fluorescence from the teeth. Another example of an ominous looking area in gingival tissues. Note the dramatic appearance through the VELscope and the large blood vessel that seems to be feeding the abnormality. This lesion was found to be dysplastic upon biopsy. Note also here that the leukoplakic area anterior to the lesion does not seem to show a loss of fluorescence. Here we have a somewhat subtle leukoplakia on the lateral border of the tongue that appears quite striking and dark under fluorescence. This lesion was biopsied and again found to be dysplastic. The lateral border of the tongue in this patient shows evidence of leukoplakia and perhaps erythroplakia as well. The large area of loss of fluorescence on the lateral border of this tongue helps confirm that this is a lesion requiring biopsy. Note that the keratotic patch closest to the molars does not seem to exhibit a loss of fluorescence. This is a particularly interesting case of a patient who complained of a funny feeling on the hard palate. As can be seen from the white light clinical photograph, very little can be seen visually, although careful palpation of the area did in fact reveal a small swelling or bump. Viewing the fluorescence response through the VELscope shows a pronounced unilateral loss of fluorescence that's hard to miss. As a result of these clinical findings, a surgical biopsy was performed with the results shown on the following slide. The biopsy showed the presence of a type of salivary gland tumor, a low-grade mucoepidermoid carcinoma. What's striking here is that this is not an epithelial-based cancer. In fact, the overlying epithelium is essentially normal. One might have thought that a visualization tool such as the VELscope would not be sensitive to this type of tissue change. In fact, this shows the sensitivity of the VELscope not only to the epithelium, but also to connective tissue changes. We saw this as it related to breaking of collagen crosslinks in our discussion of the pathogenesis of dysplasia and squamous cell carcinoma. In this particular case, we hypothesize that the loss of fluorescence arises from changes in the collagen matrix to allow and accommodate the growth of the salivary gland tumor in the connective tissue layer. Here we have a few final points to remember. Recognize normal and abnormal patterns of fluorescence. Your brain is good at pattern recognition. Try to use the underlying principles you've learned here to understand what you see with VELscope and how it relates to what you see under white light. You and your experiences are going to be your own best teacher. And as always, please use your clinical judgment and common sense. LED Dental gratefully acknowledges the contributions to this presentation of the following organizations and individuals: the BC Cancer Oral Prevention Program, the University of Washington Department of Oral Medicine, the Benjamin Dental Group, and Dr. Samsoning.